I would like to introduce Dr. Richards. He is a board certified orthopedic surgeon who joined WVU Medicine East and West Virginia Medicine, Orthopedics and Sports Medicine in June 2019. He received his medical degree from Queen's University and completed his residency in orthopedic surgery at University of Ottawa, both located in Ontario, Canada. He then completed 2 fellowships in Texas, the first in sports medicine and arthroscopy, and Plano Orthopedics and Sports Medicine, and the second in shoulder arthroscopy at the San Antonio Orthopedic Group with Stephen Burkhart, MD. A member of the Jefferson Medical Center medical staff, Dr. Richards has over 17 years of practice experience, specializing in arthroscopy, arthroscopic reconstructions of the shoulder and knee, and sports medicine. And he is located at Windmill Crossing in Charlestown. So Dr. Richards, thank you very much for joining us today and for fitting us into probably a very busy schedule.
It's my pleasure. Can you guys, all I see is my PowerPoint, so I don't know what I look like. I don't know if my hair is okay, if I'm centered in the screen.
You look great.
So, do I look okay? Am I centered?
Yes, you are, indeed.
So I turned my iPad on and put it on the picture mode so I could sort of see, make sure that I looked okay. So I look okay from my end. I just wanted to make sure I looked okay from you guys' end.
Very good.
So thank you for the introduction. Again, you went through my background. So I'm Canadian and I'm American. So I get the best of both worlds, I guess. So I've been in practice, like you said, for 17 years, and shoulders are my expertise. And I see a lot of people coming into my clinic on a daily basis and they say, my shoulder is hurting. And so how many times have I personally felt this? Well, now that I'm getting older, my shoulders hurt quite often. How many times do I hear my family complaining, calling me up on the phone saying, hey, my shoulder hurts. What do you think it is? How often do I hear it in my clinic, church, wherever? It's a common question, and I think all of us have suffered from a sore shoulder from time to time. Now, lots of times people think that, it's only athletes that have a sore shoulder, the pitcher on the baseball field, a football player that injures his shoulder tackling somebody, something like that. But generally, it's just a regular person that has a sore shoulder, and generally as we get older, we're more likely to have a sore shoulder. So it doesn't matter what you're doing. In fact, actually, this PowerPoint was made a number of years ago, but I had actually a lady tell me today she couldn't vacuum. So I thought it was hilarious when I reviewed this PowerPoint. And so I actually put a lady up vacuuming on my PowerPoint. So it doesn't matter what you do. Anything that we do potentially can cause shoulder pain. So the reason why people end up coming and seeing me isn't necessarily because they have shoulder pain, because lots of people will live with it, but it's because their shoulder pain has become a bother. It prevents them from doing the things that they want to do, whether it's just general activities or whether it's work or whether it's sport. It's become a bother. It's a nuisance, and they want to have some sort of answer as to what the cause of the shoulder pain is. So as we get older, like I said, there's a greater chance that we're going to develop some type of problem with our shoulder. And rotator cuff tears is a common thing that occurs as we get older. And if we take a look at the orthopedic literature, you can see, I'm not sure if you can see my cursor, but you can see that in one study, a person just under 50, they didn't see anybody with rotator cuff tears. You go up an extra 10 years, and now all of a sudden a person has a tear on one side. And then you go up another 10 years, essentially, and the person now has tears on both sides. So it's something that can progressively get worse. If we take a look at this other study, you can see that there's between the ages of 50 and 59, you have about a 13% chance of developing a rotator cuff tear. And then if you're between 60 and 69, you might have a 20%. And you can see that it progressively gets more and more as we get older. And you can see that people in this particular study over 81, 51% of people had a rotator cuff tear. So you can see that as we get older, the chance that we're going to develop some type of shoulder problem increases. So the shoulder, the anatomy is very complex. All of us know about the ball and socket joint. Capsule and ligamentous tissue surround the bones, and that forms our ball and socket joint. And so our shoulder joint is really called the glenohumeral joint. So here is just an anatomic picture from Netter's Atlas, which is a very common anatomic textbook that we use. And you can see this is kind of the complexity of it. I mean, from a musculoskeletal standpoint anyways, it doesn't have the nerves and blood vessels and so on, but you can see the ligamentous tissues up in here on the top diagram. You can see the muscular and tendinous tissues as well as the bursal tissue right here. And this one right here just demonstrates the socket and how the capsular tissue kind of envelopes the ball and socket in here. So what is the rotator cuff? The rotator cuff consists of 4 tendons that come from muscles. These muscles are on your shoulder blade, and as they come toward your shoulder joint, they form a tendon, and the tendon crosses the joint and attaches to the bone. And so it's 4 different muscles, but their tendons become confluent and they attach to the bone of your proximal humerus or your arm bone. And these tendons are your supraspinatus, your infraspinatus, your teres minor, and your subscapularis. So how do you get a rotator cuff tear? Like the literature demonstrated, most of the time it's just wear and tear. It's just as we get older, it wears. The rotator cuff doesn't have a great blood supply, so it ends up tearing. Or it can come from a traumatic event, a fall, a dislocation, a car accident, motorcycle accident, etc. So what are the complaints that patients come in and talk about? Lateral shoulder pain, so pain right in here. Lots of times patients will say, I'll say, so how long has your shoulder hurt? And they look at me like I don't know what I'm talking about, that I failed anatomy in medical school or something like that, because they'll look at me and go, Dr. Richards, this isn't my shoulder, this is my arm. And it's like, no, I get it. But the shoulder, the way it's innervated, the way the nerves work, instead of feeling the pain necessarily up in here, lots of patients will feel it right down in here. So pain with activity, especially moving their arms overhead, will cause pain. Night pain, people sleeping on their shoulder. In fact, I just did a study right now that I'm in the process of writing up. I've done the statistics looking at sleep position and rotator cuff pathology. Weakness is something definitely that people will complain of. Some people will have such a profound injury to their rotator cuff that they literally can't reach overhead, and then obviously decreased range of motion. So whatever you do, this pain, this weakness is going to prevent you from doing the things that you want to do. So that's the chief complaints that we see with rotator cuff pathology. So how do we make the diagnosis? Well, a thorough history. And it's funny, like sometimes my patients, when I'm talking to them, they talk to me as if I should know more about their particular story, but every story is different. So when the patient comes into clinic, I like to sit down with them and take a thorough history, listen to their story, hear what happened, hear where it hurts, see what their deficiencies are. Then after that, we move towards the physical examination, and there's specific things that we do in order to assess the shoulder, range of motion, strength, special tests to figure out exactly what may or may not be going on. After we've done that, we can send them for x-rays. Arthrograms, that's an x-ray where we inject dye. That's less commonly done these days, but historically was done before ultrasound and MRI scan was utilized. Ultrasounds can be used. They demonstrate rotator cuff pathology, but not as accurately or specifically as an MRI scan. And then obviously an MRI scan is excellent at determining whether or not someone has a torn rotator cuff or not. So here are some plain x-rays that we do. Lots of times patients will come in and say, well, if you're just going to do an MRI scan, why do we need to get an x-ray as well? Well, again, if you can follow my cursor, This right here, that's called your acromioclavicular joint. Sometimes you can get arthritis there. That can cause pain. So that shows up very good on an x-ray. This view right here, the middle view, this is your acromion right here. This is part of your shoulder blade, and it curves. And sometimes the curve can be so significant that it'll pinch the rotator cuff. So it's nice to see what that looks like on x-ray, because we can take a little burr and burr this down to create greater space if we need to do that when we're doing surgery. And then this last view, the bottom right, this one demonstrates this one doesn't, the specific x-ray does not demonstrate arthritis, but this particular view can demonstrate arthritic changes. Then obviously the MRI scan is very helpful. This view up here, this is a massive rotator cuff tear. If you can see my cursor, here is the torn rotator cuff. It looks like a little dumbbell right here. That should be attached all the way over here. And so this is a significant rotator cuff tear. And how we end up fixing these is we try to get this tendon, using a bunch of different techniques, back down to bone right here. This is looking at your shoulder as if you're sort of looking straight at the person. The person's head would be over in this area right here. Here's a cross section right here. This is good. Again, it shows us the front rotator cuff tendon, the subscapularis. It's intact in this situation. Shows us the back rotator cuff tendon, the teres minor, right back through here. So again, MRI scan gives us a lot of detailed information. This right here, this football looking thing is the biceps tendon, and it's very helpful to look at to see if the person is suffering from some bicep problems. So how do we deal with this? Anti-inflammatory medications, physical therapy helps. Cortisone injections historically have been used, but I don't like to use them very much because they have a detrimental effect on both tendon and cartilage. And also there's some literature that demonstrates if you've had cortisone injections, you're more likely not to heal your rotator cuff repair, and you're more likely to have post-operative complications. So I use cortisone injections sparingly. PRP stands for platelet-rich plasma. It's a blood product that we take from the patient themselves, spin it down in a centrifuge to platelet-rich plasma, and we take that and we inject the repair with that. That also can be used in the office for people that have shoulder problems as well. And then finally, surgery, open versus arthroscopic. And in these days, anybody that's doing open arthroscopic or open rotator cuff repairs probably shouldn't be doing them. They should be done arthroscopically in 2021. So here's some arthroscopic pictures. This is the ball that you see right here on the left. This right here where my cursor is moving back and forth, that's the footprint for the rotator cuff. So the tendon needs to get back down into here. This right deep down in here, that's the socket. So we're looking through the rotator cuff into the socket. This right here, this is rotator cuff tissue. And again, we need to get this back down onto bone. So here, using different techniques, you can see that no longer you can see the hole. The rotator cuff has been repaired and fixed nicely back down to bone. So here are some repair basics. Not all tears are the same, and so we need to be able to determine how we need to repair these. And so this is kind of this we call a crescent-shaped tear, and it will repair directly back down to bone. This right here is a U-shaped tear, and if we try to take this point where my cursor is down here and try to put it right there, that's not how it wants to come together. In fact, it will be too tight and it will re-tear. So what we need to do is we need to come side to side with sutures, almost like you're doing up your shoes, make it so it's a smaller configuration, then we can fix that to bone. So here's some video, and this video is old video, and the video is old on purpose because this is video that I did 15 years ago. And I want you guys to see that even 15 years ago, when things were less sophisticated in our world, that we could actually repair these things arthroscopically. Can you guys see that okay? So that's the shoulder. The thing So this is a little shaving device, and I'm cleaning up bursal tissue so I can assess the rotator cuff better. Once I've done that, I kind of clean up the footprint, take off some of the tissue, soft tissue off that, clean it up. This is a burning device that ablates soft tissue. Now I'm looking at the rotator cuff tear, and I'm going to try to figure out how it needs to come back together. So it's a U-shaped type of tear. So I'm going to put my grasper in here. I'm going to pull it, see how it wants to come together. So it looks like it wants to come, that's the front part. The back part seems like it wants to come forward as well. So now what I need to do is I need to sort of put some sutures through the front part here with this little device. We have more sophisticated devices now to do it, but it passes the suture almost like a little handheld sewing machine. And then we're going to use a penetrating device and come through the back portion of the rotator cuff and grab the suture. And we can pull it through the other side. And you can see just by looking at that, it's starting to close things down. So now I'll tie a knot to close this down. Well, I guess I want to pass another suture first. So I didn't think I got close enough to the apex of the tear, so I'm going to pass another suture there. Again, using that little device. Using my penetrating device again. The penetrator is coming through a little plastic device called a cannula, and that just allows us to access from outside in through this device. It's like a straw. It allows us to get in and out of the joint simply without binding up with soft tissue. So there I've tied up my sutures, and you can see that that started to close everything down. So I need to put more sutures in just to close this down a little bit more to make the actual reconstruction down to bone more manageable. So again, just using that device. Want to take as big of bites as we can just so that there's less likelihood, it's less likely for the sutures to tear out of the soft tissue. So there we have it closed down, but we're still not finished. We need to secure it down to bone. So now we're going to use this suture anchor system. So we make a little pilot hole into the bone. Now this guy, this particular individual, he was a construction worker. I was practicing in Phoenix at the time, and he worked in Las Vegas. And so his bone was very hard. So I had to tap the bone to make sure that the anchor would go in without breaking or cracking. This anchor is a biodegradable anchor. They no longer look like this. They're white instead of clear. And they have better, what we call osteoinductive properties. So we got one anchor in. We're going to put another anchor in. Again, skip the point with the tap in this situation. We're just putting the anchor in. Now we're going to take these sutures that are in the anchor themselves, and we're going to pass them through the tendon in the same fashion as we did before, one in the front portion of the cuff, or what we call the anterior leaflet. And then we'll pass one through the posterior leaflet as well. So we're going to do it with every single one of those sutures. And there were 2 sutures or 4 suture limbs in each of those suture anchors, and we're going to pass those through the tendon so we can reconstruct it nicely back down to bone. And the reason we put it down to bone and just not close it up with those initial sutures is because it won't stay reconstructed, and the bone is the source of the blood supply that's going to actually help it scar down and heal appropriately. So we've tied our knots, and now we have it reconstructed, and you can see that now that hole that was there before when I first started is no longer there. And now I'm moving the arm into internal and external rotation, and you can see that that tendon moves in concert with the proximal humerus when I do that. So that reassures me that the tendon's been reconstructed nicely back down to bone. So when we take a look at the literature, arthroscopic techniques versus open techniques, you can take a look at all these numbers down the side, and you know the good to excellent results are pretty high. I can think of in my practice in 17 years, and this, I mean, there's probably more than this, but to my knowledge, only 4 people have ever retorn their rotator cuffs. Now, again, that's 4 people that have come back to see me. One of them was a guy that was too vigorous in his post-op rehabilitation. One guy was a guy that was young and he rode a dirt bike and he got bucked off his dirt bike again and re-injured his shoulder. Another one was a lady that fell. And then the last one, I cannot remember, but it's rare for people to actually come back with problems. And even if they do re-tear or partially re-tear, patients do very, very well with this particular procedure. Some people say, well, what about the big ones that are bigger than 5 centimeters, which are massive? And when I was in training with Dr. Burkhart, I was surprised because I always thought there's no way he's going to be able to repair this type of tear. It's just way too big. And every single time he'd do it. And it's been my experience as well in practice that even these massive tears you can repair, and even these massive repairs that we do and we repair, you can see that even these individuals have very good outcomes as far as good to excellent results go. So whether it's a small tear, like a partial thickness tear that we repair, whether it's a massive tear that has the whole ball and socket joint exposed, when we do these repairs arthroscopically, patients do very well. My post-op protocol, 6 weeks in a sling. You get to come out of the sling to work on a little passive external rotation, which is just taking a wooden spoon or a stick and doing this, and then working on some elbow flexion and extension like that. And then depending upon the size of the tear, when they come out of the sling at 6 weeks, they'll do either 6 weeks of stretching exercises or 9 weeks of stretching exercises. Those are the 4 exercises that I do. They're very simple. Then at 12 or 15 weeks, they'll start their strengthening. They'll use a TheraBand, a red TheraBand, like just a rubber band, and they'll work on some specific exercises, 4 of them again. And then at 18 to 21 weeks from the time of surgery, then I'll send them to formal physical therapy. So in conclusion, rotator cuff tears, which cause the big ouch in our shoulder, they commonly occur as we age. Partial tears that are not significant can be treated non-operatively. Small tears can become bigger, just like a hole in the knee of your jeans. It could stay a small hole in the knee of your jeans for years, or you could have it happen one day and the next day you fall and all of a sudden it's this big hole in the knee of your jeans. Arthroscopic reconstructions of the rotator cuff are possible. And then at this time, it's definitely the gold standard. I don't believe, like in this day and age, that anybody should be getting an open rotator cuff repair when we can do them arthroscopically. Thanks.
Doctor, question. In one of the slides, you listed reports from a Dr. Proctor. Do you know where that person was?
Dr. Proctor?
Yeah.
I don't know. I don't know Dr. Proctor personally.
Okay. I knew a female proctor up in Pennsylvania years ago. Thanks.
So we have a couple questions in chat. Mary Crathern asked, what should we be doing to minimize injury?
So the reality is that, staying fit, staying healthy is always important, but rotator cuff pathology is just something that occurs, so there's no golden message with regards to what can I do in order to prevent myself from developing a rotator cuff tear. In a lot of ways, it's similar to saying, what do I do to stop getting wrinkles, or what do I do to stop getting gray hair? It just is going to happen. So the fitter we are, the healthier we are, the better we take care of ourselves, the more likely we'll do well. Now, that being said, if we stay active, there's a greater chance that we may develop a rotator cuff tear. But if that occurs and you're healthy and fit and so on, then the likelihood of having some sort of post-operative complication is going to be less. So really, there's nothing specific that I could say, like, don't stop lifting things, don't stop riding your bike. Like, I can't say do all those types of things. It's just be healthy and manage yourself. And just like gray hair and wrinkles, it's just going to happen if it's going to happen.
And Amy Panzarella asked if you have the same philosophy pertaining to arthroscopic surgery about knees.
So knees, yes. So I mean, I do knee surgery as well. Knees, weight, like for people that are carrying too much weight, that's a real significant problem for knees. It can be a problem for shoulders, but because shoulders aren't weight bearing, it's not as big a problem. From a knee standpoint, I would say probably the best thing we can do for our knees is stay active, stay healthy, and be as close to our ideal body weight as possible. And if we can do that, then we'll protect our knees. But likewise, the genetics that we have are going to predispose us to developing different degenerative changes within our knees as well. And so different types of injuries that people have, whether it's like, fractures or ligament injuries or so on, that might predispose an individual to developing arthritis in their knee. But as far as just someone that has a normal knee, what do you do to make sure that you don't develop problems? Stay as active as you can and stay as close to your ideal weight as possible.
Are there any other questions? Comments? Well, for me, I was utterly fascinated by watching the video. I think that certainly captivated a few of us. Amy's asked you to come back with more pics. Maybe next time we'll pause on lunch.
Yeah, that was a bad idea on my part to be eating during that presentation, but I wasn't thinking it through.
Well, that's why I did arthroscopic surgery, because I'm a little queasy with blood. I don't see much blood that way. I pass out.
Well, you found a good field for yourself, that's for sure.
I'm just kidding. That's what I tell my kids all the time. Like, blood makes me queasy. They say, well, how can it? You're a surgeon.
All right. Well, are there any announcements? I don't want to miss the opportunity to share any news. Leo, if you have any announcements about upcoming service events, anybody please step in if I've missed something.
I don't think we really have any major updates. The donation collection for the animal shelter project will actually begin on the 25th of January. So we're pushing the timeline back a little bit. But other than that, there's really no change in the timeline. I still have to talk to Kevin Brackens about the painting, but we have the painting project assessed. We just need to determine what all it's going to take to get it done.
And if people have donations for the animal shelter donations, again, that is a joint effort with Tiffany Hine with Hollywood Toastmasters. If we have donations, how should we deal with that? Do you have any recommendation or news on that?
We've had a couple of people drop some stuff off with Tara in her office at the Hilton. Either if you have something and you don't want to go anywhere, let us know, and either myself or Tiffany, or maybe even Raul, someone can help us out and come pick stuff up. If it's there and it's available, let us know. We'll come get it. We don't want to miss giving something to the shelter by just not telling someone you have it.
Yeah, I'd be happy to come get anything. Nobody wants to go out.
Great. And Josh, can you plug, sorry if I stepped on somebody, but I just want to make sure Josh plugged the blood drive information after this next person asks a question. Or who did I miss?
Yeah, no, I was just gonna say about the what was dropped off here at the Hampton. Raul, if you're gonna pick up, or I was gonna contact Tiffany, and more people are welcome to drop off here, but what's here now is taking up a lot of space back here because it's 15 cases of paper towels. So if you want me to call Tiffany and work something out to get that picked up, that'd be great. But if there's, other smaller items or not so big of a stash of 15 cases of paper towels, feel free to drop them at the Hampton. And then every now and then I can contact Tiffany for coordinating pickup.
Yeah, that's fine. I'll reach out to her as soon as we get off this meeting. And if she's not available, I'll come by tomorrow and I'll pick it all up.
Awesome. All right. Just let me know. It's at the Hampton. Thanks, Roll.
Do you only have paper towels because you already let the dog eat all the food?
Yeah. Yeah.
Well, thank you
No,
guys.
Kevin Brackens donated the paper towels. He went and got them and dropped them off here.
Great. Thank you guys for spearheading that, and keep us updated with any news on that. Josh.
So the next blood drive is actually one of the small in-between blood drives for the big community ones, and it is actually already full. So all 50 or 60 slots that we had are already filled for that one. So the next big one will be in March. I think I sent Leo all the dates for all the blood drives. I think it's like something like the 26th. It's always on a Friday for the big ones. So that'll be the next one where we'll have about 150 slots to fill. So about 3 times the size.
Is there any other news or announcements for the group?
Oh, this is Carol Cable. Yes, hi. Can you hear me? I'm not sure if I'm on. All right.
We can hear you.
I've sent out letters for all that I think or the tax letters for donations to Christmas for Charities. And if there's anyone that hasn't received a letter for their donation, if you'd let me know, I'll be glad to get it out to them.
Great, thank you. All right, well, again, thank you, Dr. Richards, very much for your presentation and videos today. It was great to have you on and meet you and hear what you have to share with us. I think we're all pretty fascinated by that. Well, I think next week is the social. So I'm sure that Chris Puller will share information out about that for, to the club. And otherwise, everybody have a wonderful week.
You too. Thank you.
Thanks, guys.
Thank you.